start?
Go for it, my friend.
Okay. Okay, so the chief complaint is hypercalcemia.
Wow, we got it. No, we got to stop there. You can't
Yeah.
hypercalcemia to a clinical problem solver and not stop. And actually, I actually want to do this with Robbie. So, Robbie, maybe what I'll do is I'll just set up like when people should be concerned for hypercalcemia, and then pass it to you for just like your schema and like how you approach it. So what I love about electrolytes is that in general, it's so hard to predict an electrolyte abnormality until you actually measure that lab abnormality. Meaning, we'll hear from Chiara, but many times a patient will go to their primary care doctor, they'll send run-of-the-mill labs, and there'll be a hyponatremia, a hyperkalemia, a hypercalcemia, and that will prompt the primary care doctor to refer their patient to the emergency department. But so the question I have for the audience, and we'll pause for like 20 seconds, how can you predict hypercalcemia before the lab comes back? What's a unique combination of findings that may clue you into this specific diagnosis? Put it in the chat. I'm going to pass the mic to Robbie to talk about the schema, and then Robbie can loop back and tell you what that combination of findings is.
Yeah, I love that setup. I think that the schema really is a question of what are you trying to do with the schema for hypercalcemia. And if you're trying to understand hypercalcemia, I think it's best to simply divide it into PTH and non-PTH mechanisms. So whenever you see a calcium that's elevated, your reflex is to understand whether it is a problem with the PTH arm or a problem independent of the PTH arm. And the fun fact there is to recognize that PTH-related hypercalcemia refers to any cause of PTH, any level of PTH that is not suppressed. So simply put, when you get a calcium, you want to know the PTH reflexively. And the PTH, anything less than a suppressed PTH, means that PTH is the cause of the problem. And that is diagnostic of hyperparathyroidism, which comes in many flavors: primary, secondary, tertiary, and unfortunately, even malignant parathyroid disease. So that's the key question in terms of beginning to understand it. The deeper reflection here is, what does it mean when hypercalcemia is the chief concern? How is that different than hypercalcemia being a small part of a case rather than the chief concern? We all worry about cancer in patients with hypercalcemia, but what is the probability that somebody with cancer will report that their chief concern is hypercalcemia? Think about that. You have metastatic disease in most people with hypercalcemia. Why would your calcium be your primary problem? So, two small reflections. If you're trying to understand hypercalcemia, start with, is it PTH or not? If hypercalcemia dominates the landscape, it probably is a more benign cause of hypercalcemia, because the sinister causes, namely malignancy, are often widespread and devastating, and so devastating that they leave less room for the calcium to take up, mitigating its rise to the chief concern. So that's where I'd start. I'll pass the mic to Prof. Rez to see what the chat has said, because I actually haven't been looking at it, and any other thoughts he has.
Thank you, Robbie. The chat has been exceptional as usual, and there's no right answer here, but several of you had mentioned, what I was thinking, that is, when you have not just constipation, not just, one symptom, but if you have the combination of polyuria and constipation, that's a pretty strong clue to hypercalcemia. So if your patient's having a lot of, urine output and is complaining of constipation, you should think about hypercalcemia. The one, unique combination that should prompt you to think of that. All right, Chiara, mic back to you.
Okay, that's the discussion, and I wish I knew all of this before. So I will present like as it happened in this order. For the HPI, he is a 68-year-old male with a recent diagnosis of multiple myeloma, and he was hospitalized twice for persistent hypercalcemia. So 2 months ago, he was hospitalized first for his multiple myeloma study, where there was evidence of hypercalcemia. He received zoledronic acid and his cancer treatment with bortezomib. Then a month ago, he went to an ambulatory oncology consult, and he was evidence of hypercalcemia, and he was hospitalized, received fluids, steroids, and diuretics. A little more of his past medical history. He has hypertension treated with bisoprolol, nifedipine, and irbesartan. Then he has gout treated with allopurinol, and his recent diagnosis of in this present year of multiple myeloma. His debut was with lumbar stenosis and pathologic fractures, and his complications was bilateral lower limb paresthesis, urinary incontinence, for which he was using by that time Foley catheter in a permanent way. I can stop here.
Yeah, Kara, it's amazing how much the lay of the land changes when you mention this piece of medical history. And I'll just share a little bit about multiple myeloma as an illness script, and then pass the mic to Prof. to use that information, any other information that struck him here. And I'd say multiple myeloma is a very unfortunate diagnosis, primarily because there's no risk factor for the disease apart from age. So it's an age-related condition in the vast majority of people. And the clinical presentation reflects two things. It reflects the presence of abnormal plasma cells, which define this disorder. So you have to have more than 10% plasma cells. And those plasma cells do things locally right then and there. And what they do is they cause lytic bone lesions. So you'll find lytic bone lesions in almost 100% of patients with multiple myeloma. The other aspects of multiple myeloma have to do with a paraneoplastic effect, not the actual plasma cells themselves, but rather the paraprotein that they secrete. You'll find a paraprotein in 98% of multiple myeloma, which if you have time to stop and think, you wait, what? There's 2% of multiple myeloma that doesn't secrete a paraprotein? The answer is yes, and probably a good thing to look up once you have a better understanding of multiple myeloma itself. So those are the two fundamental things. There's abnormal plasma cells. They're in the bone marrow. They're about 10%. Then you need to have 10% in the bone marrow, and they cause local effects by destroying the bone. And then there are paraneoplastic effects. And the paraneoplastic effects are the other part of the CRAB mnemonic, which we use to remind ourselves, with the C being hypercalcemia, the R being renal insufficiency, and the A being anemia, and B being bone lesions. And so it is true that all those three things, the hypercalcemia, the renal insufficiency, and the anemia, are all actually paraneoplastic. The anemia, you may think, is because of bone marrow invasion, but that's actually not true. Plasma cells secrete certain molecules that suppress erythropoiesis, and that's why, even though you only have 10% plasma cells, your bone marrow is devoid of red blood cells. It's also why you don't get leukopenia and thrombocytopenia in patients with multiple myeloma. It's very rare to get those things. And those paraproteins go on and deposit into the kidney, and you actually have secretion of rank and ranklidin, paraneoplastic phenomenon that cause hypercalcemia. So it's a devastating disease caused by a small number, 10% or so, of plasma cells that cause local bone destruction, but devastating effects elsewhere. It is a very morbid diagnosis, but there is more and more fancy smancy treatment, which is very specific treatment for protein degradation and protein metabolism, including bortezomib, which is a proteasome inhibitor and actually inhibits the secretion of these paraproteins. So it's a fascinating disease, and unfortunately a very morbid one that is undoubtedly related to what's going on to this patient here. And for more, I'll pass the mic to Prof. Red.
So this is a really interesting case, and one that I think is more, at least for right now, a management dilemma than a diagnostic dilemma, meaning there's no reason for us to pivot to another cause of hypercalcemia just yet, because we have a very good explanation for this patient's hypercalcemia being the myeloma. Now, if the myeloma is being treated properly, then we got to create a DDX for refractory hypercalcemia in the context of bisphosphonate therapy. So right now I have more my management hat on. And when it comes time to managing hypercalcemia, there's stuff that we do acutely and stuff that we do for more long-term calcium management. What do we do acutely for the management of hypercalcemia? We give fluid. You give fluid. Rarely, if the calcium, like the severity is very high, you might give a calcium mimetic like calcitonin, which has a short half-life and creates tachyphylaxis, or the body gets used to it rather quickly. So you're going to give a lot of fluid, but as you're giving a lot of fluid, you're saying, okay, how can I keep the calcium low? And it depends on the etiology. In this case, the physicians gave zoledronic acid, a bisphosphonate, which is a very good approach to managing hypercalcemia in the context of malignancy. The bisphosphonates, what they do, if you ask the question, like, what determines the calcium in the blood? Where does calcium truly exist? The majority is in bones. You have calcium phosphate making up your bones. And so the majority of calcium is in bones, like the majority of potassium is in cells. So when there's an imbalance between osteoblast and osteoclast, you can see significant abnormalities in calcium level. Osteoblasts are involved in strengthening bone and utilizing that calcium and incorporating it into the bone or into the osteoid cells, while osteoclasts, they sort of lyse the bone, they liberate the calcium, they weaken the bone. So what bisphosphonates do, they increase osteoblast activity, thereby lowering calcium levels. In fact, like a contraindications to bisphosphonates in patients who have CKD and osteoporosis would be hypocalcemia, because they can cause severe hypocalcemia. Another medication is these rank ligand products, which affect the degree of osteoclastic activity. We have a good schema for this, like mechanistically. So the question is, do you need a rank ligand inhibitor? And I think the way I would frame it right now is just bisphosphonate refractory hypercalcemia in the context of myeloma. And if that DDX might be that the myeloma is advancing and the bisphosphonate's not effective, it could be that there's another cause of hypercalcemia. But regardless, acutely, we need to give this patient fluid, and we're going to get a sense of how high the calcium is momentarily from Chiara. Mike, back to you, Chiara.
Nice. Okay, so for this first hospitalization, this was the third hospitalization. So he received again zoledronic acid, and as hypercalcemia was persisted, he was first some labs were taken. No, I'm sorry, I will go first with the vital. The good thing is that he was an asymptomatic, there was an asymptomatic hypercalcemia. The only positive was that he had decreased motor strength in his lower extremities, but this was probably a consequence of his lumbar stenosis. In spite of that, vitals were okay. So some labs were taken. His hemoglobin was low in 9.9. Leukocytes were slightly elevated in 11, but neutrophils were 8.5, and platelets were 270. Then creatinine was slightly elevated in 1.27. Urea was 96. His ionic calcium values were in 2.05, phos was 2.33, magnesium was 2.16, sodium was in 138, and potassium was 5.3. I can stop here maybe.
That sounds great. What I'm going to just show the audience briefly is sort of the schema I was describing with regard to hypercalcemia. And really what Chiara is showing here is that what matters most is the ionized calcium, not the total calcium. At the end of the day, it's the free ionized calcium that is most important to the cells at the cellular level. And normal ionized calcium, at least in our lab here, is like, I believe, less than 1.3, 1.2, 1.3. So this is quite severe hypercalcemia. So already I'm thinking I need to give this patient IV fluid. Already I'm thinking that bisphosphonates is probably not going to be effective because the patient's on zoledronic acid. So I may consider denosumab, but acutely I may ask the question, should this patient be given a calcium mimetic to manage this hypercalcemia? That would be beyond, honestly, my comfort. But let me just share with you this schema and then pass the mic to Robbie. All right, can you all see this? Yeah, you can see this sort of the calcium. Okay, this is the bloodstream. And these are the organs that are really involved in calcium homeostasis. You have the bone, you have here the liver, the kidney, the small intestines. But if you think about like, where do the majority of our medications work? It's going to be the bone. Of course, the fluid, you're giving a lot of fluid, so you're going to try to get rid of the calcium. The time you get in trouble is when you have kidney injury and you can't excrete the excess calcium from the kidney, then you can see significant hypercalcemia. But if you look at the bone, your bisphosphonates act right here on the osteoblast. And what does it do? It takes calcium and puts it into the bone. The denosumab or your rank ligand inhibitors, they act right here. And what does this do? Rank ligand actually stimulates osteoclasts that liberates calcium. So you want to inhibit rank ligand, thereby decrease osteoclast. So when you have hypercalcemia, increase osteoblast activity, decrease osteoclast activity. So that's what I'm thinking acutely. But again, we're just putting a Band-Aid on the hypercalcemia. The real question is, why is this patient having such degrees of hypercalcemia despite getting zoledronic acid? That's a schema I don't have. And I would just, research that. Like, why would this happen? Is it advancement of disease? Is it another cause? Is it some kind of genetic mutation that, keeps them from responding to zoledronic acid? Are they not being administered it properly? But Mike to Robbie to comment on all the other data and whatever else he wants.
I can talk about whatever I want. Oh, what a privilege. I don't know. I've also never been in a situation before where the patient is so severely hypercalcemic despite zoledronic acid. And I think that whenever you're in the space of unfamiliarity, you have to question the assumptions you're making. So in real life, I'd be like, wait, did he actually get zoledronic acid? Has there been a medication administrator? Like some of the things that actually make sure that you're not in the wrong problem space. And once that's happened, then you have to check your assumption. So make sure that you're actually in the right problem. Did he actually get the zoledronic acid? Make sure that your working diagnosis is in fact correct. So have we really rigorously gone to disprove other competing causes of hypercalcemia? And the question is, when you have such a rare cause, what's the point of looking for other ones? And that's where you remind yourself that common causes can complicate the picture. We actually had a case on VMR of a patient who had both primary hyperparathyroidism and multiple myeloma, and it was VMR 300, which is 2 years ago. But it was something that fooled us because the patient had elevated PTH, but also turned out to have multiple myeloma. So should we go back and revisit that hypothesis? The truth is that no matter what we find, and even if the patient has 5 causes of hypercalcemia all acting at the same time, I think it's still a little unusual that the bisphosphonates, if received, aren't working. And so by analogical reasoning, I would ask myself, well, how do bisphosphonates work? And is there a reason that they're not working in this specific patient? And that's when I would actually try to look up, is vitamin D deficiency a reason why bisphosphonates don't work? Because we
Is he muted or did he pause? I'm not sure what he was, where he was going with that, but I'm looking at his picture. It's so funny.
No.
Okay, he's back.
perfect. It's perfect. My Zoom was telling me shut up and move on, and so
No, Bobby, please finish your thought about the vitamin D.
No, I was just going to say, make sure that you're not making any assumptions, both about the diagnosis and about the treatment that's been received. And then you're left with two possibilities. Either it's just an extreme case that requires denosumab and advanced therapies, or there's a reason the bisphosphonate isn't working. And so it makes you wonder whether you should go back to your bone mineralization and say, if I'm trying to get the calcium in the bone, does it need something else to get there? And just by analogical reasoning, I would wonder if vitamin D is a crucial factor here. And it's certainly worth a quick Google search. And I will stop now.
I wanted to say two things. One is that Robbie said bone mineralization, which just like warms my heart. Like he's getting so down to the mechanism. And then two, like what you guys are witnessing is like Robbie and I trying to come up with a schema in real time on a topic we have no clue about, which is a lot of fun to do. So this is a really interesting exercise.
Oh, by the way, I'll just preface all this by in the back room, Kiara said, oh, this is an easy, simple case. So just know what we're up with when Kiara thinks this is simple. All right, Kiara, back to you.
It is a curious case. It's not that. I will continue. Okay, so you're totally right. The problem in this case was that this patient was treated in a private hospital, and so he had not insurance, so he was paying for all his treatment. So before asking him denosumab, he was paying for all his cancer treatment and everything. So we start by reviewing his previous labs. So we found that in his first hospitalization, he had elevated PTH. So further labs were ordered. So we ordered first oncology consult and endocrinology consult, and after that some further labs. So we found that PTH was high in almost 400. 404. Vitamin D, 25 vitamin D was in 17.8, which normal was supposed to be more than 30. We ordered 24 urinary calcium, which was 316, which was elevated too. Urinary creatinine was 22.8. and creatinine depuration was low in 171. Also, we ordered in the oncology part some labs to see how the multiple myeloma was, if it was like a progression of the disease. So it was in serum, there was serum lambda chains elevated and kappa chains were normal. And an SPEP showed high alpha and beta regions elevated, normal albumin, and there was no monoclonal peak by this time. So yes, this is what we did by that time.
Yara, this is absolutely fascinating. Because I rambled a lot last time, I'd love I'll leave the juicy part for Prof. Rez as the high PTH and actually reflect on the multiple myeloma monitoring. So, you know, oncologists are experts at this, but you'll almost always, there's an internist along with the oncologist for the primary care. And so it's not uncommon for us to be in this space alongside the patient. And usually for recurrence and for monitoring, usually we're getting interval imaging. So most things we actually take pictures of to see, is that cancer shrinking? so on and so forth. And there's not that many situations where we rely on blood markers or tumor markers to be confident that the disease is actually in remission. But there are some exceptions, and multiple myeloma is one of them. If your patient had a positive paraprotein and elevated serum free light chains, the degree in reduction of the serum and the monoclonal protein and in the serum free light chain ratio correlates with disease response. That isn't the only thing. We also, I don't know what the criteria is, but I know that there are also repeat bone marrow biopsies done to ensure that the plasma cell burden has diminished as well. But here it's hard not to say, hey, the monoclonal spike is gone and the serum free light chain ratio may be lower than before. So there's now a disconnect between the severity of the hypercalcemia and the trajectory of the multiple myeloma, highlighting quite frankly, as outstanding detective work by the people taking care of him here, Chiara, to make that point. It is very easy to keep going on the train of worsening disease, especially as Chiara was implying or suggesting that he had his care at other places. So that makes it even harder to track down all the records and the information. So we can talk about the medicine, ask Professor to do that, but this is massive detective work and honestly life-changing for this patient, for you to uncover this history and to show this disconnect. So really, really marvelous job. And I'll pass the mic to Prof. Rez to teach us about the PTH findings.
This is really, really fascinating. And I want to say one thing that we didn't comment on in the previous aliquot. Look at the patient's potassium and look at the patient's creatinine. For someone, and I'm not sure if this represents acute kidney injury. And actually, let me just ask you, Chiara, during that hospitalization, when the patient received fluid, did these values normalize?
Eventually, they normalized, but he at first he had high creatinine and he was considered like an acute kidney injury. And also he had like a decrease, not a severe decrease, but he had a decreased 24-hour urine volume. And he was in a Foley catheter, it was very well quantified, but it improved eventually.
Terrific. So this is extremely helpful. And the reason I asked that question is if someone has a malignancy or has decreased muscle mass, that creatinine is not going to correlate with their glomerular filtration rate. And in that context, a cystatin C is actually more helpful, because the only way someone can have chronic hyperkalemia, which is not the case here, is through chronic kidney disease. That's the only way you can have persistent hyperkalemia. And the reason that becomes important is because if you have elevated PTH levels, it can be secondary to kidney disease. Now, there's two reasons why that's not the case here. Because we know that you get tertiary hyperparathyroidism in the context of CKD. And why does that occur? Well, it occurs for two reasons. One is you become hypocalcemic, you become hyperphosphatemic, and you have a stimulation for PTH secretion from the parathyroid gland. It can become problematic when the PTH is very high because it can affect the bone mineralization through activation of the osteoclast, weakening the bone. But the reason we know this is not related to the kidney, most importantly, is that the creatinine normalized. So that's not causing the high PTH. And then secondly, when you have hyperparathyroidism in the context of kidney disease, you should expect hypocalcemia, not hypercalcemia. Because why? The kidney is responsible for 1-alpha hydroxylation of 25D, which then allows for calcium reabsorption from the gastrointestinal tract. But if you have impaired 1-alpha hydroxylation, you're going to have impaired absorption, and that's when you start getting low calcium levels. So here, we've ruled out kidney disease as the cause of the elevated PTH. We've ruled out myeloma as the cause of the elevated PTH based on Robbie's excellent discussion and the information that Chiara brought to us. So now we're left with parathyroid disease in the form of an adenoma or hyperplasia of the parathyroid gland. There's one condition you can consider as well, which is familial hypocalciuric hypercalcemia, but the urine calcium being this elevated pretty much excludes that condition if I'm doing the references right with the lab over there. So what to do next? What to do next is take a base rate approach and say, hey, there's something wrong with the parathyroid gland, and I'm not going to deviate from that until I don't find anything there. So now I would be in search for an adenoma or hyperplasia of the parathyroid gland, because maybe this patient needs resection of an adenoma and all of a sudden the calcium will normalize. I will say one other thing, that it's really important to take this sort of stepwise approach. And I'm sure the clinicians did that, to start with the PTH. And interestingly, if you got the PTH that told you the hypercalcemia, would you have gone searching for the myeloma? Just like in this case where we got the myeloma and we weren't necessarily going and searching for the PTH, it's only through the refractory nature of the hypercalcemia that we had to pause and say, why is this bisphosphonate not working? Is the myeloma advancing? Or is there another diagnosis at play? And if there is another diagnosis, why not apply the most common condition? This case is absolutely brilliant. And VMR 300, thank you for leading the way. Before I give the mic to Chiara, Robbie, anything else to add on that?
Yeah, I think that was an absolutely brilliant analysis. And I just wanted to point out just how hard it is to suspect primary hyperparathyroidism in this patient. He's the wrong gender, the wrong age, so women much more than men, usually middle-aged patients, and 90% have mild to moderate hypercalcemia. So let's be clear. We're talking about an older man with severe hypercalcemia refractory to bisphosphonates. So to me, you start to wonder, are you dealing with something very unusual within the parathyroid gland? And what that could be, who knows? But there's 4 unusual things here. He's a man who is older, who has hypercalcemia refractory to bisphosphonates, and who has a PTH level 10 times the upper limit of normal. So that is very worrisome, that he might be dealing with a massive adenoma or even maybe a parathyroid carcinoma. So just to point out that we're talking a lot of illness scripts today about all the, like, zooming on these. This is not your classic case of primary hyperparathyroidism for those 4 reasons. Hopefully they are just severe manifestations of parathyroid, but they're very, very unusual. Yeah, it's certainly not. I can see how you can overlook hyperparathyroidism here because it's just that weird, but you can't overlook a PTH of 400. All right, Chiara, mic to you.
So this is the reason why Friday's VMRs ends very early, because you already get the answer very soon. So endocrinology consult asked for a CT contrast neck with a 4D protocol, and they showed a nodular density in the posterior region of the right thyroid lobe. So at first, of course, common things are common, but as he had the background of multiple myeloma, they were worried about this being like a plasmacytoma or something bad. So also a parathyroid gammagraphy was ordered, and it showed a focal nodulary activity that suggested parathyroid adenoma. So finally, he had surgery like 2 weeks later, and pathology showed it was a parathyroid adenoma, and he has now normal calcium levels. So it was a primary hyperthyroidism.
Oh my God, I don't even, this is gonna be like, I'm so glad that all of you here, I'm so glad that I got to learn from this incredible case. There's so much to learn here about when to pivot, repivot, how, I mean, I think this patient is the definition of the rare, to have a common disease and a rare disease, but actually a rare manifestation of a common disease, to have primary hyperparathyroidism as an older man. I mean, I don't know what to say. This is so humbling. It just goes to show you, I think, that there are rules in medicine, and those rules are very helpful in most people, but they can be so incredibly poetically and artistically broken in some people. So thank you, Chiara, for a masterclass presentation and a very educational case. And I'll pass the mic to Prof. Rez for his reflection.
I want to echo that, Robbie. And I also want to say that we went from a patient who we were worried about, like truly worried about, who now actually has a good prognosis. Like we have such great advancement in the treatment of myeloma, and the adenoma has been resected. So I'm hoping that this patient actually does well for the years to come. So I think it's a good conclusion to an epic journey in diagnostic reasoning. This is such a magical case. Wow. I'm just like, I can't wait to reflect on it. Thank you so much, Kiara. Any teaching points you want to share before we give the mic to, wow, Deborah and Shema doing the teaching points together. I've never seen that before.
As we already said, first it's important to first think about the common thing, even if the presentation is not common, because I remember in clinical reasoning, that first to think in common things, and the second step is to think about common things with rare presentations. So this was the step we followed, especially because this patient wasn't in this possibility to order many times. So this is why we prefer to review his order labs instead of ordering new ones. So this is, for me, to remember first the common things.
You couldn't have said it any better. That was absolutely superb. I wish that's the, like, Reza did this last time. If there was a highlight for a 30-second highlight for this VMR, it's that beautiful 30 seconds, Kiara. Thank you. All right, I don't know who to pass the mic to first, so I'll let you guys decide who's going to start our wonderful teaching points. I guess you guys haven't decided.
Hello, everyone. Deborah and I, we did it together in any way, also describing. So it's actually a unique day today. So then I would start. So we have the chief complaint of hypercalcemia, which was also the chief complaint last Friday. And as we know, if we think of it, the unique combination of polyuria and constipation that should let you think of hypercalcemia. And also we're talking about the short QT time in the EKG. And then also we were talking about some pathophysiology again, about the osteoblasts and the osteoclasts. As you know, the clasts we are stealing the calcium from the bone, leading to high calcium, and the blasts build the bone. And the thing is, when we talk about hypercalcemia is it PTH mediated or not? If it's PTH mediated, we learned that where is this chloride phos ratio, if it's above 33, we would rather think of a PTH mediated process. And then we were talking about multiple myeloma, and I lead the mic to the great Deborah.
Okay. The multiple myeloma, we said that was age-related, and then 10% that had abnormal plasma cells in bone marrow, and then we had the paraprotein that 98% of the patient have and 2% doesn't have. And I always think about the what Robbie teaches about the crab that buddies bark, because the bone that caused the anemia, that caused the renal, and that elevated the calcium, and the anemia, in this case, the plasma cells secrete substance that inhibited the erythropoiesis, and then the bone lesions secrete HANK-Al that leads to the lytic bone lesions through the stimulation of osteoclast. And the medications, we talk about the bortezomib, that it's a protease inhibitor that inhibiting proteolysis. We talk about the hyaluronic acid, that is a biphosphate that think of the upright position that cause mucositis and increase the osteoblast activity and can cause hypocalcemia. And then the denosumab, it's a HANK-Al inhibitor. And we ask if this hypocalcemia, despite the biphosphate therapy, the medication was wrong, the multiple myeloma was progressing or had another cause. And we talk about the CKD, that is a high PTH that could be secondary of the hypoparathyroidism and expect hypocalcemia due to impairment of 1-alpha hydrolyzation. And then in this case, we thought about the high PTH could be caused by the adenoma or a hyperplasia. So thank you, everyone. It was a great case.
Wow. Oh, go ahead, Shama. You're going to say something.
Oh no, we were, and the last thing that Reza also mentioned, the familial hypocalciuric hypercalcemia, exactly. And we excluded this one because we had very high calcium in the urine. Yeah, this I just wanted to mention, I recently read about it. For the FHH, it usually, we are asymptomatic, and this was very interesting to me. Yeah.
Wow, I am just like stunned right now because, okay, I just want everyone to know I'm trying to learn French and I'm still stuck on où est la toilette? Il s'appelle Rabi, collègue moi, et brilliant. But anyways, I'm still learning the basics and I'm struggling, and these individuals are teaching medicine in English. Like I'm just, and like teaching it as well as anyone could teach it. So you two should be very proud of yourselves. And thank you for doing that. I feel like very inspired right now.
I'm going to jump in and also take more time, because I always do, to also say that I think Reza is proving that you have a lot in common with him, because you see what he did. He took the time to practice. He didn't just say, I'm learning French. He also took 30 seconds of your time to also practice in front of you to learn and grow. And so we appreciate all of you learning and practicing with us. So yeah, Prof. Rez, we see you, and we see your ongoing efforts to learn and grow, just like
Robbie, I'm not even lying to you. I was running around UCLA and I was like, how am I going to introduce Robbie as my colleague? And I kept like saying Robbie out loud. And I swear I got a couple of looks from those young undergraduate soccer players. Like,
Folks, look out for ambulance bringing Reza to your hospital for people confusing him for going crazy at UCLA.
Il s'appelle Robbie Gerard.
All right, y'all. See you next time. Bye.